Let's talk about euglycemic DKA. What's up, you guys? It's your ER pharmacist, Little Pharma. We are going uphill again, so distracting ourselves from being out of breath and talking about euglycemic DKA. Specifically, I want to talk about euglycemic DKA in relation to SGLT2 inhibitors. So SGLT2 inhibitors are our gliflozin, so dapagliflozin, canagliflozin, empagliflozin. Brand names are things like Jardiance, Invokana, yada yada. How do these medications cause euglycemic DKA? In other words, DKA without an elevated blood sugar. So these medications work by releasing glucose from the urine. Your body realizes there's less glucose. It produces less insulin. It increases production of glucagon, which increases fatty acid oxidation, leading to ketones in the blood, causing a acidosis, specifically an anion gap metabolic acidosis. So how do these patients present? Typically, they'll present with a normal sugar, slightly short of breath, and potentially some abdominal pain. They'll be acidotic with an anion gap, elevated anion gap, low bicarb, and again, normal sugar. So how do we treat these patients? Treatment is largely similar to normal DKA. So we're going to want to start them on an insulin drip. We're going to want to give them fluids, but you're going to want to give that dextrose containing fluid much earlier, potentially right away. So if their blood sugar is less than 200, which it likely will be, hence the euglycemic, then you'll want to start dextrose containing fluids immediately. And of course, making sure their potassium is not low before starting your insulin drip. And again, just like normal DKA, you'll continue this until their gap closes. And of course, holding the SGLT2 inhibitor until this resolves. Let me know what questions you have in the comments. I'm going to go climb the rest of this mountain. Whew, I'm out of breath. That's euglycemic DKA caused by SGLT2 inhibitors.